Thank you so much, sir. It's an absolute pleasure to be here today for the 4th International Diabetes Summit. It's my 3rd visit for the same. And today we are going to talk about basal insulin for euglycemia. And it's obviously everybody knows about basal insulin. There's nothing much new that I'm going to talk about. We'll just be revisiting a classic philosophy and look at whether we are using to the optimum levels or not. So if you look at the journey of basal insulin thus far, 1922 insulin is discovered, and then there's a huge jump in the treatment of diabetes. But after a period of time, people realized that we were treating people with short-acting insulin, and this was not exactly simulating the physiological insulin of our body. So they realized it was necessary to change the insulin so that it acts for a little longer. And in this process, there were many trials. They started using a lot of things, gels and others, diffusion methods, and those did not work for a very, very long time. Till in 1936, the first addition of protamine came in, and where it was successful in providing the first slow-release insulin. That, again, was not very physiological. Then we had NPH, and for a very long time, as you can see there, 1946, NPH came in. And today, we might not be using a lot of NPH because of a lot of factors, but at that point of time, it was a major, major discovery, because for a very long time after that, as you can see, from 1946 to 2000, where the first basal analog was used, till then, NPH was the only basal insulin, or supposedly intermediate basal insulin that was being used. In 2000, we got our analog, we got glargine, and then we had detamir, and then further on, we have got the second generation basal insulin, the glargine 300 and the degludec. The mechanisms of action are different. It's all about making it stay a little longer in the body and getting slowly released. So some way it's about changing the pH, such that it gets precipitated in the physiological pH of the body. Somewhere it's about making it into dihexamers and allowing it to bind with albumin, thereby bringing about a slow release. Somewhere as in U300 glargine, it's about making it more compact, and they were a little more clustered and a slower release. Or in degludec, where there's a multi-hexamer chain which are put together, and there's a dissociation of zinc which gradually allows the insulin to be released. So these are the pictorial representations of the same thing. So PK/PD profile of these basal insulins that we have now. As you can see there, you can look at the NPH there. This is the NPH, and it was nowhere very near to the basal insulin that we would want. An ideal basal insulin should act for 24 hours. It should be absolutely peakless. There should be no peaks and troughs, and it should have no major hypoglycemia. It should control the sugar levels very well. Now, obviously, NPH did not do all of that very well, and we were looking forward to something else, something better. And to bring about that better thing, we got glargine. Now, if you look at the profile of glargine, that's green, it's much better, it's much peakless, but nevertheless it's not absolutely a flat thing. And then if you move on from the glargine 100 to the glargine 300, flatter, but still some amount of peak there, and also the degludec, flatter still, but then 300 and degludec almost the same, but even then a little bit of peak does remain. So we're still not at the absolute basal insulin, but we are almost there, as we shall see subsequently. So these are the basal insulins that are being used, and we know about them. NPH can be used twice, detamir can be used twice, glargine can be used twice, but ideally once, and the others are, because they are ultra long acting, therefore they have to be used only once. Now, comparing glargine with NPH, as we just said, because glargine was made to overcome the shortcomings of NPH, so obviously in the test of time, you would expect glargine to perform better. And in most of the trials, it did, in terms of HbA1c reduction, in terms of lower levels of hypoglycemia. As you can see, in terms of hypoglycemia, much lower in type 1 as well as in type 2, though in some studies, they were still parallel. But crossly, all in all, we did understand that glargine fared much better when it came to hypoglycemia. As you can see, some studies showing to the tune of minus 46% difference with glargine as compared to NPH. Now, detamir versus NPH, again, very similar. Most of the studies in terms of, HbA1c are not grossly different, but in terms of hypoglycemia, yes, quite different in favor of detamir as compared to NPH. Then is where we had the comparison that we are talking about now, which will be discussed in the subsequent, presentations, the comparison between the very long-acting basal insulins, the comparison between degludec and glargine. Now, depending on which symposium you're standing in, you'll hear it to the tune of either in favor of degludec or in favor of glargine. But grossly, if we talk about it, there have been some trials which have told us that degludec is better, but there were a lot of limitations with those trials because they had a much lower HbA1c cutoff. The time of administration of degludec was at the main evening meal, whereas glargine was given as per their wish. The ADA criteria when applied, less than 70 when applied, took away a lot of difference between these two molecules. And then, of course, when you're giving degludec, because you're giving it giving a molecule which is staying for a very long time in the body, you're concerned about supraphysiological levels of the insulin being stacked into the body, being there in the body. So maybe probably what we understand today is something very similar to what this real-world clinical trial told us. It was not a very big trial, but it did give us a very clear picture about how U300 and IDEC are more similar than different. And I'm sure we're going to hear more about it in the third talk of this session. So because now we have this many basal insulins in our hand, most of the bodies, whether it is IDF or it's like the ACE, where they have said that, after 2 oral hypoglycemics, if you're not reaching there, then, and you're thinking of starting insulin, rather than, anything else, start off with basal first. And for those who are wondering whether basal is going to do the trick, we'll look at why they're saying basal first. And this is what they're saying, how the dose that has to be given in terms of type 1, type 2 diabetes. Even ADA 2020 also says that it's the most convenient insulin, initial insulin regimen, which can be added to metformin as well as other agents. And this is where they place it. Injectable first, 2020 says GLP-1, but then after that it says basal insulin. So in spite of this many bodies telling us that, the first insulin to be started is basal insulin, we still do not see as much use of basal insulin as perhaps we would have wanted with this kind of data in our hands. Because probably what's happening is that, the reason probably why the RSSDI has also put a tick to the premix is because you're concerned that most of our patients who are coming there, they have not only the fasting which is raised, they also have a high PP, and only taking care of the fasting is not going to do the job. So that's why we need to understand whether this proposition actually stands, whether it's good actually to start off with basal and then think of basal plus subsequently. So this is Be Smart, the study which said basal early strategies to maximize A1C reduction. And this was basically, it was an international panel expert study, and they did categorically say that basal insulin is the most effective option for insulin initiation, most convenient and crucial for achieving glycemic control. What orals can you continue? You can actually continue all orals. There are people who believe that secretagogues should be stopped. Well, most of us believe that they should be tapered, brought down. But if you're going to stop it, remember, if you're taking away a secretagogue, if you're taking away sulfonylurea, you have to give that amount of insulin. You just cannot put in 10 units of basal insulin, take away all the sulfonylurea. Patients are going to come back with very high sugar levels. So the best thing is maybe you just titrate it, bring it down, or continue and just follow up for hypoglycemia, because we just saw the sulfonylurea is actually not responsible for a lot of hypoglycemia that we think they are. Thiazolidine preferably not given because of the risk of edema and heart failure. The others, of course, can be continued. So when you're looking at a diabetic patient, you want the fasting controlled, you want the PP controlled, you want the HbA1c controlled, and you do not want glycemic variability. Now, is the basal insulin going to do the job for you there? So the concept is attack the base. You attack the base, the entire building comes down. That's how you will look at glycemic control. That it's going to bring down the fasting. Yes, you're going to give it at night. It's bringing down the fasting. But once it brings down the fasting, the entire baseline goes down low. So once the fasting comes down, the PP also comes down. The PP surges also come down. That is what we call fixing the fasting first. And it does work very well, as we have seen in a number of trials, that you can see that the basal insulin normalizing fasting as expected, and PP thereby because of bringing down the threshold from where the PP excursion is starting. So this was a group of, HbA1c of less than 7. Now you have a patient of a very high HbA1c of more than 10, and you're thinking, is basal only going to do the trick? Can I really, depend on basal to take care of this? So this is what a meta-analysis of this many studies say. As you can see, their baseline, and you're going to look at LANMET from 9.1 to 7.1, a decrease in 2%, and that is with the basal insulin, going with the concept of fixing the fasting first. So we do have a number of other studies also, because we understand this being that the higher you go with the HbA1c, the greater contribution of the fasting blood sugar. So when you're bringing down the fasting blood sugar, obviously you're bringing down the HbA1c. So this is also Indian data that we have, the Fine Asia real world study, where we can see at a difference of 6 months from initiation, there was around 2.3% A1C reduction. And that coming from basal insulin is actually a lot. In terms of glycemic variability, it is taking care of the peaks, as we just saw, and it's taking care of the troughs, because it's much better. The glargine is doing better than NPH, lesser risk, of one over the other in terms of bringing down the troughs. So no peaks, no troughs, lesser peaks, lesser troughs is what is giving us a lesser glycemic variability. In terms of premix, now if you're getting a molecule that is giving you a FPG reduction and a moderate PPG reduction, then why would you go for premix? We all use premix, and we know the uses of premix where, the PP is that high, where it's not going to be good enough to only bring down the fasting and, depend on it. But having said that, we know that weight gain is more with premix, the chances of hypoglycemia are more with premix, and we have seen that in insulin-naive patients, there are a number of trials, I'm just quoting one, where basal insulin did in fact fare better in terms of HbA1c reduction as compared to premix insulin. But that's again, I guess, one tussle that's going to take a long time. But we do have evidence in favor of basal insulin. Persistence, treatment persistence, improved treatment persistence has been seen, as we've understood, because of the, the action on glycemic variability. Importantly is one point where all the bodies seem to say start with 10 units. And that is where some people, including myself and David Davis, et al., and a lot of, I believe, do not agree, because one size certainly does not fit all. You can't have a 60 kg or 80 kg and a 100 kg and HbA1c of 8 or 9%, and everybody start off with 10 units and achieve success. That's not going to happen. So you have to titrate the dose accordingly based on the weight and the HbA1c. And then the titration. How do you titrate? You just can't write a dose and send the patient away and that's done. You cannot do that. So you need to titrate definitely. You can do it every alternate day. You can do it every third day. You can do it once a week. So there are a number of regimens, number of recommendations as to how you should increase the insulin. This is CID. This is B-Smart. There are a number of recommendations. You can just go through any. But this is one study where they looked at patients changing the dose by themselves versus the doctor changing it. And as you can see, the results there quite similar, which means to say if your patient is smart enough to take care of the changes himself, you can allow him or her to do so. So these are the frequently asked questions with basal insulin. Just like to take them one by one. Is there a maximum amount of insulin that you can use, basal insulin? There is no such thing as maximum. You usually, resume titration when the fasting is more than 126 and you go on. Now you're giving basal and the patient is getting daytime hypoglycemia, not fasting, not nocturnal, but daytime. So do you need to bring the basal down also? If you're using secretagogues, then bring the secretagogue down, keep the basal where it is. If it's not secretagogues, then bring the basal down. When is it appropriate to add a basal plus? When you've given it 3 months' time to 6 months' time, and the requirement is more than 1 unit per kg. Then is when you need to understand that basal itself is not doing the trick. What if the patient is sick? Basal continues, because we know bolus we take away, basal we continue. Patient goes to the hospital, has been on some other treatment, comes back. What do? You usually go back to the previous regimen, but try to understand it according to the feeding pattern of the patient. Now the patient says, I'm not very sure whether I took the insulin or not. What should I do? Don't take the dose. Test more frequently. I've injected twice by mistake, double dose. What do? Just test more frequently, take extra snack. What if I've missed the dose? Less than 6 hours, take usual dose. 6 to 12 hours, take 50% of the dose. More than 12 hours, ideally, omit the dose. Stacking does not occur with the new onset insulin. We don't have much time, can't go into the details, but as such, it does not occur. And how much will you go to maximum? 1 unit per kg. Don't go beyond that, but it's not going to help. Follow-up very essential initially at 72 hours and at 1 week, 1 month, 3 months, and 6 months. So this is one case where we saw fasting PP HbA1c high, and she was initiated on basal insulin, and basal insulin did take care of all of these and brought it down. And this is a classic case which we see quite often because we are using it quite often. So coming to my last slide, what have I learned? What have I learned in my attempt to present basal insulin to you? I've learned that the introduction and improvisation of basal insulin, thank God it came, somebody thought of it, was a giant step in diabetes care. And today, protein engineering has enabled us to develop analogs that have almost mimicked basal requirement, not totally, but we are almost there. Don't think it's only going to bring down the fasting. PP will also come down, so will the glycemic variability. But for that, you just can't let the patient go. Titration is the basic rule that you have to follow. And all in all, as it stands today, basal insulin is a very, very important tool in the diabetes treatment armamentarium. So use it. Thank you so much. Laughter, as they say, is the best medicine. But when it comes to a diabetic, insulin is perhaps a little higher on the list. Thank you.
Thank you, Dr. Arundhati.